moving earlier in this disease, of course, has been where immune therapy has been a standard of care, particularly with BCG for non-muscle invasive disease. So what are some of the challenges, Rob, in developing checkpoint inhibition therapy for patients who are refractory to BCG?
So we all deal at that interface. I mean, the interface of urology and medical oncology historically has been at the neoadjuvant chemotherapy level. In academic centers where the unmet need of BCG refractory disease, which is real, these patients are patients, many of whom are technically fit to have cystectomy. Cystectomy is potentially curative, the patients who want to maintain their bladders. For the last 10 years, many of us have been engaged with looking at other kinds of therapies, targeted agents, earlier in the course and trying to, in a sense, convert BCG refractory disease to a responsive disease using a variety of relatively soft measures of outcome. And this has been part of the problem with drug development. And actually, Dean has been heavily involved working with the FDA and the AUA to try to develop a pathway for drug development. So as we begin to think about bringing systemic therapies, right? So because heretofore, obviously, BCG is an intravesical therapy. As we begin to interface with intravenously administered systemic therapies, which have, albeit toxicities that our urologic colleagues would typically be uncomfortable working with, it's how do you interface to do the trials? And actually, we can figure that out. The larger issue is actually going to be what happens if we're successful? We all know that in the broader community in the US, the interface with community urology and medical oncology is a somewhat different dynamic, and it's really going to require rewiring that. Now, that's a good problem to have when we get there. The trials that are beginning to look at this are now just beginning. There are a number of these trials, including several potential randomized trials that will begin to address BCG combinations with checkpoint alone. So it's a particularly challenging place, but again, it's big time unmet need. And there is a bit of an FDA pathway to a regulatory approval, and Dean probably should comment on that.
Yeah, so I think this is really important. You know, our FDA colleagues have actually met with academic leaders in the field and said, how can we be proactive with regard to the various subsets? And in point of fact, actually worked with us with regard to paradigms for approval for these drugs. So a good example is this BCG-refractory, BCG unresponsive population. Standard of care for those patients actually is a cystectomy. And many patients say, you know, I have so-called superficial disease or early stage disease. And as one of my patients said, you know, I've had my bladder for 70 years. I'm kind of fond of it. I'd like to keep it. And so in point of fact, actually, this is an area that has been under intense study. So the FDA said, well, we can't randomize against cystectomy. We can't randomize against ineffective therapy because we really don't have good effective therapies now. So they have accepted that a single non-comparator arm with endpoints of response and durability of response at landmark intervals will be satisfactory for approval in that disease setting. So now we're seeing, for example, atezolizumab plus BCG, and we're seeing pembrolizumab used in that setting, and there we're seeing that the systemic side effects of the drugs are, in terms of concern, they're still of concern, but we still have a disease that can be quite lethal. You know, these patients can have 10 to up to 15% nodal positivity at the time of cystectomy, so we need to be, aware of that. It's moving down further. We have the patients who there are studies looking at BCG. Relapsing disease. They do a little bit better. There's actually but there's a trial looking at that population too. And here we're getting into the radiation plus, plus checkpoint blockade. And in point of fact, different courses of radiation therapy may affect immunological exposure or exposure of neoantigens. It may not be the same amount of radiation that we use typically for bladder preservation. And so those studies are now ongoing. And then we're very soon, I think, in the US and in Europe, about to see studies looking at checkpoint blockade as frontline therapy. And that's going to be much more challenging. Again, we still need our medical oncology colleagues, along with our surgical or our urologic colleagues, to be able to do these studies together because of the toxicities we're seeing. But that's also an unmet need because we've had international shortages of BCG. We've had companies leave the space, and we now have 2 strains left in the world, the Tokyo and Tice, but Canoa is now discontinued. So we need drugs in that space.
And just to remind the audience is that bladder cancer is the most expensive disease to manage in the United States. Now, where the bulk of those are lower grade, lower stage recurrent disease, but the reality is there is potential for these therapeutics to really become pretty critical along the way, and one day its earlier use in a major sort of economic impact is there. And we also have to figure out how long to treat, because this is also a group of patients that indefinite therapy is likely to be a significant
So you think
challenge.
moving it earlier will save cost?
So
Well, if you could treat one time and not have to continue
Depends on
to.
efficacy, right?
So you're both bringing up very good points, and that is that actually some of the designs of these trials now that are under consideration is BCG requires, the standard care is maintenance. The standard care is 3 years of maintenance of BCG. And the trials are looking at checkpoint blockade for a far shorter period of time, up to a year, and shorter treatment, looking at durability. So these are important questions to ask, and hopefully we can answer them together.
Yep.
Absolutely.
I think in a health economic sense, if you can reduce the burden of having to take a patient to cystectomy in that early, the high grade superficial disease patient is the one that is most unpredictable for me. You don't know whether if you send them to cystectomy, you think, wow, we really probably didn't need to take that bladder out, or alternatively, whether the patient will be dead in 6 months from metastatic disease. It's a big spectrum. So from a pharmaco and health economics perspective, if you can reduce the need for cystectomy by 10 or 20%, that could have a real impact on the cost of the disease. And then also, if you have some of the relapsing and refractory disease that responds, and even if you delay the next need for treatment, that may have a significant saving and outweigh the cost of the therapy.
So I think we have a lot of very important questions to ask. I think that this is an unmet medical need, and I think that this is simply going to have an important impact on both the quantity and quality of life of our patients.